Sir, is my screen visible?
Yes, please go ahead.
Yes. So, from Team Gloderma, uh, a very warm welcome to all the respected doctors. At Gloderma, our purpose is to elevate lives. Our mission goes beyond just creating products. It's about fostering change in the lives of our customers, employees, and communities. At Gloderma, our core values are meaningful innovation, unwavering commitment to quality and safety, continuous improvement, results through teamwork, and our aspirational core value is customer success above all else. Gloderma has launched 7 plus first time in India products. Gloderma has 400 plus enterprising Glodermians. We are the 138th ranked pharma company in the country with a 700 plus distribution networks, 9,000 plus associated dermatologists, and we have a skilled research and development team which develops innovative formulations. At Gloderma, we have a product mix of antifungals, moisturizers, acne care, and hair care. Along with that, we have psoriasis care, topical steroids, vitiligo care, and nutraceuticals. Gloderma is India's first company to make all the products paraben-free, sulfate-free, and detergent-free. At Gloderma, patient safety is of paramount concern. Introducing Moise, the clinically proven range of moisturizers and cleansers. Moise is formulated to be non-comedogenic, non-irritating, and it has a skin-friendly pH. Under Moise, we have gentle cleansers. Under gentle cleansers, we have Moise cleansing lotion and Moise scented bar. Under moisturizing creams, we have Moise Excel Hydro Boost cream, Moise skin barrier restoring cream, and Moise daily moisturizing cream. Under moisturizing lotion, we have Moise LMF 48 face and body lotion. Introducing Kivon, the most advanced range of ketoconazole. Under Kivon range, we have Kivon soap, Kivon Stay On lotion, which is ketoconazole 2% lotion, Kivon zip, and Kivon cream. Kivon finishes the task completely. Introducing the new and improved MinoBoost range, minoxidil topical solutions and tablets, the complete hair regrowth therapy. Under MinoBoost, we have MinoBoost 5, MinoBoost F5, MinoBoost F10, and MinoBoost ProGain. MinoBoost ProGain is enriched with procapyl, anagen, and transcutol P. It is available with spray applicator and dropper. We also have MinoBoost 2.5 mg core tablets. Introducing Keraboost tablets, the unique hair growth booster. Keraboost tablets are enriched with D-biotin, N-acetyl, and L-cysteine. It is made with IDDS technology for site-specific drug release in 3 phases. It is available in Trichology pack of 30 tablets and 10 tablet strip. Introducing Facitinib for the management of autoimmune skin disorders. Facitinib is available as Facitinib ointment, which is tofacitinib 2% ointment, Facitinib XR tablets, which is tofacitinib 11 mg extended release tablets, and Facitinib 5 mg tablets. Introducing Sanosin Baby, the premium pediatric skincare range. So Gloderma has collaborated with Mann and Schroeder Cosmetics to bring world-class Dermatest certified natural and safe baby skincare products to Indian mothers. Sanosin Baby made in Germany. It is Germany's premium baby skincare range. One globe, one formulation, 40 plus years of expertise in baby skincare and presence in more than 70 plus countries. Sanosin Baby has gained the trust and confidence of more than 250,000 plus Indian mothers. Sanosin Baby is made with more than 90% natural ingredients. It is SLS and paraben free. It is original Dermatest certified, clinically tested hypoallergenic. It is made with hydrolyzed milk protein and organic olive oil. Under Sanosin Baby, we have Sanosin Baby Bath and Shampoo, Sanosin Baby Care Oil, Sanosin Baby Care Cream, Sanosin Baby Sun Cream, and Sanosin Baby Care Lotion. Thank you.
So thank you, Gloderma team, for the support. So we're going to start with the cases. So let me share my screen. Right. All of you can see my screen, I hope.
Yes.
Okay. So we're going to go to the cases. So the first case, so Anmol, you're the only person here. Dr. Sisir will join in. So we'll have to start with you, if that's okay.
Yes, sir.
So, so the way it works is that for those of you who are new to this sort of system, we have 6 cases here in the quiz today, and the CPC's quiz, and we're going to discuss the clinical history first, and then the histology photos, and then we'll see if we can arrive at a consensus as to what is the likely diagnosis based on the description. So the first case is a 50-year-old female who's complained of raised itchy lesions in the hands and legs for 3 months. On examination, she had multiple well-defined violations to hyperpigmented pruritic papules and small plaques distributed over the palms, legs, and feet. Lesions with petechiae, some of them with petechiae gradually increasing in size and number. That's a history given. And the DD was lichen planus. And this is the clinical photographs. So you can see a few papules here. And that's, of course, Mehendi. You can see a few lichenoid papules here. And this is the biopsy was taken from the papule on the leg, on the calf. So that's the clinical history. Let's minimize this. Okay. So let me go to the histology images. So this is the scanner view. Nandakumar sir, do you want to guide Anmol on this, please?
Yeah. Dr. Anmol, you can start describing the findings.
Sir, so before we start, sorry, just introduction to Dr. Anmol. Dr. Anmol is a dermatologist, and he won the. He was one of the quiz winners last time, and that's why he's on the panel today.
Very good.
We're hand holding him while he goes through the cases. Yeah, over to you, Dr. Anmol. Welcome.
So at scanner view, I can see the most of the pathology is limited to upper dermis. There is like band shape infiltrate, which is in the upper dermis. And at low power, I can see that granular layer seems to be prominent and the red ridges are slightly pointed at places. And that's all I can see at this scanner view.
Okay, let me go higher power. Okay. I think this power is enough for now, I guess. Okay.
So I can see in background there are many dilated capillaries as well. I can see that there is the granular layer which I was thinking was prominent. It is also seen at this power. There is slight orthokeratosis. Basal layer, I am not able to see any prominent vacuolization at this power, but the infiltrate is upper dermal and almost hugging the epidermis. And the infiltrate is prominently, I think, lymphocytic.
So you agree that it is a, lichenoid type of infiltrate, isn't it? Almost band-like upper dermal infiltrate.
Yes, sir.
Very close to the basal cell layer. And the epidermis shows hyperkeratosis, little bit of hypergranulosis, irregular acanthosis. I think when we describe the histopathology, it is always better to go about in an orderly fashion. Start from the most superficial layer and work downwards. So we have hyperkeratosis, hypergranulosis, irregular acanthosis is there. And basal cell layer, according to you, appears more or less intact, isn't it? We will go closer.
There were one foci there were where there was basal cell vacuolization in the
photo. At the tip of the reader ridges, you can see a bit of basal cell vacuolation is there.
Yes.
Can you just zoom in a little bit at the basal cell vacuolation? Yes. And what else we see there?
So lymphocytes.
We can see the lymphocytes.
Pigment incontinence.
Yeah. So a few pigment-laden cells are also seen. The lymphocytes, which appear quite mature, are seeing almost hugging the basal cell layer, isn't it?
Yes, sir.
And as you rightly said, there are quite a number of capillaries, dilated capillaries. Do you see that often in before that, what is the possible diagnosis? Clinical possibility was lichen planus. Is it are the findings consistent with lichen planus, or do you have a difference of opinion?
Sir, I think they are consistent with lichen planus.
Lichen planus. How do you explain the presence of so many capillaries. Is that usual finding in classical lichen planus?
Sir, I thought this is because of the site-related changes, biopsies taken from leg. Although I did consider lichenoid PPD in my diagnosis, but the history was and the findings, I thought this was more suggestive of lichen planus.
So you attribute the dilated capillaries to the anatomical site of biopsy, isn't it?
Yes, sir.
Probably related to stasis changes, isn't it?
Yes, sir.
Right. So, any other comment that you would like to make regarding the nature? I mean, the density of the infiltrate. Is it as dense as you see in an acute lichen planus?
No, sir. It is slightly sparse than I would expect to see in acute lichen planus.
And the very focal nature of basal cell vacuolation. These two findings could be due to what?
So treatment.
Treatment, or it may be a sign of healing.
Healing.
Maybe a sign of healing lesion. It may be. Plus, it shows some features of stasis. What else you would agree that this is lichen planus? One last comment from my side. What else you would like to look at the slide before you sign off the report as lichen planus?
So I would like to rule out any drug-induced changes like apoptotic keratinocytes, eosinophils.
Very good. And any deeper component of infiltrate, isn't it? Infiltrate. Also, since there are so many proliferated capillaries, look for features of vasculitis. Look for any deposition of extraneous material like mucin, the deeper component, of course. And then we can, with CPC, we can offer a diagnosis of lichen planus and a comment that it may be a healing lesion and it might be showing changes of stasis also, isn't it? Right.
Yes, sir.
Very, very well described, Dr. Anmol. You are from which institution?
So ASIC Medical College, Faridabad.
Faridabad. Very good, very good. Right. That's all from me. Yeah.
Excellent, sir. I think we've covered everything. One comment from me is that I think this is a very difficult case if you don't see the clinical history and you don't do CPC. This is an extremely difficult case to diagnose histopathology alone because the lichenoid infiltrate is very sparse and focal. And in a otherwise routine biopsy, seeing focal lichenoid infiltrates or focal vacuolar change does not automatically make us think of lichen planus.
Absolutely.
But given the context, yes. And one other feature that I would like to point out is that in lichen planus, often it is underrated, but we see areas of atrophy associated with areas of acanthosis. So this area is acanthotic, while this is atrophic. Here there's hardly, the epidermis is hardly few cells thick. So this feature is actually particularly seen in lichenoid disorders and particularly lichen planus. There is irregular acanthosis, and that is very important clue to the diagnosis of lichen planus. I mean, here you can see it's more lichenoid. You can see other thing is that we didn't mention is the pigment incontinence. And often in lichen planus, because of the lichenoid interface change, there is often a bit of collagen thickening and a bit of papillodermal scarring, which is often also seen, especially in the legs. And that is an important feature. And yes, it's bang on. The dilated capillaries should not be mistaken for a vasculitis or anything else or a vascular proliferation. Yeah, I think otherwise it's well covered. And I thought I put this case because it is not a routine lichen planus case, and everybody can diagnose a routine lichen planus. But to diagnose this as lichen planus, you need to know your Dermpath really well, and also do you have to correlate with the clinical. If you're not correlating with the clinical, this is not a diagnosis you can make otherwise. Any comments from Manoj Singh, sir? Any comments? Is he there?
I would, Sasi, can we go down on the basal layer of the epidermis?
Yes.
Track the basal layer, please.
Yeah.
Yeah. Now this is that area which he described about a little bit of spongiosis and basal cell degeneration and so on. Now just track this. Now in many places, one does see these cells also going into these inflammatory cells going into the epidermis, in the lower part of the epidermis.
Yes.
And, I think that is altogether a very significant number. If you go further, just track the basal layer. Track the basal layer again. Let's go further. Let's go left or right. Yeah, 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 yeah. Okay. Now in this area again. Now this is not that area, but again there is, there is this, these lymphocyte-like cells which are going into the epidermis. So I would keep the diagnosis of lichen planus, even though if you are thinking of lichen planus, then as Nand said, this is nice to say that this is a continuing lichen planus with healing on the upper side. Healing is going on, but continuing activity in the lower part. But I think I would like to keep and work up this case as some kind of maybe if not a mycosis, then at least suspicious.
So, if I may interject, I think one thing we did not mention and discuss is the epidermal spongiosis, and that is significant. You see here, there is quite marked epidermal spongiosis. I think the spongiosis is actually quite reactive to stasis, and also the patient actually probably scratching the lesion. And I think those lymphocytes are actually exocytosis rather than epidermotropism because they're single lymphocytes. They're not in groups, just to clarify to others who may be also wondering. And in my opinion, this is just a reactive lymphocytic exocytosis rather than being a marker of MF, and also the clinical, also important because the patient has got isolated papules, and that is not usually a feature of MF. And it's very important, I think, to appreciate the desmosomes here and the spongiosis. In the absence of that, yes, definitely we may suspect the lymphocytes to be suspected to be epidermotropism, but these I think are just normal exocytosis in the context of epidermal spongiosis and the stasis changes.
Yeah. But what you say about the itching and scratching thing is again, perhaps sort of borne out by the fact that there is significant hyperkeratosis on top, and some kind of mild parakeratosis, maybe a few of these cells going into the keratin. So that scratching reaction in the epidermis, I think, is there. But
Yes.
I would be a little uncomfortable saying that this is a lichen planus full stop. Even healing lichen planus, continuing lichen planus, whatever. I think this patient would benefit with the clinical follow-up.
Okay. I don't know if we have Dr. Curious in the panel, but Dr. Raman sir, I know you're curious and not there, but if you want to interject, please feel free to comment. Dr. Raman sir is in the panel, but he wanted to be silent today. But if you're free, if you want to comment, please do. Okay. So we'll go on to the marking now to see what everybody has answered. Let's go back and so case number 1, let's see what everybody has answered. So the diagnosis lichen planus was given by the majority of people, and I think that should receive 1 point if everybody agrees.
Yeah.
Yeah. Manoj Singh sir, you have any objection to calling
fine.
utilizing lichen planus? Lichen aureus, I'm not sure lichen aureus is a reasonable answer, because lichen aureus you often see extravasation of RBC and a bit more perivascular lymphocytic infiltrate, which is absent here. This is not a perivascular dermatitis, so that is the reason I don't think lichen aureus is the right answer. Manoj Singh sir and Nandakumar sir, do you have any objections?
No, I wouldn't give any credit for lichen
I don't
aureus.
think so. No.
Okay. Contact lichenoid hypersensitivity, again, there's no history of contact dermatitis, and the clinical history, I think, is relevant here. There are a few scattered discrete papules, and that cannot be a contact dermatitis. So I think that cannot be given. Similarly, Majochi purpura, lichenoid dermatitis, NOS is a reasonable answer because they probably thought this is not classical lichen planus. But clinically, it looks like lichen planus, and it is lichen planus. So if somebody is calling it lichenoid dermatitis NOS and asking the clinician to correlate, that can be given some marks. But what do you say, sir? How many marks should we give this?
I think lichenoid dermatitis deserves that. Somebody has gone. I mean, maybe a half mark or a
Half
quarter
mark,
or
I think
something.
so, half mark, because they should really make a diagnosis based on CPC. But Nandakumar sir, half or 0.75? What is your opinion?
Half mark, 0.5.
0.5. Okay, I thought 0.5 as well. Pigment purpuric dermatosis in the same spectrum. Atrophic lichen planus, I guess they saw the atrophy. As I said, there is a bit of atrophy there. So I guess it's in the same spectrum of lichen planus. So I don't know. Can be given 1 or 0.75? Up to you. What is the consensus?
We can. I feel we can give 1 mark.
1. Manoj Singh sir, do you have any objection?
Atrophic. It's not atrophic. Actually, it isn't atrophic.
There are areas of atrophy, so it's not purely atrophic. I mean, you can't call it atrophic, so 0.75 also is probably reasonable. It's not really atrophic clinically. It's not atrophic lichen planus.
Maybe just because this person has kind of is going towards
half. Okay, half I don't think is unreasonable because it's not really clinically. It's not atrophic lichen planus. Lichen planus, fair enough.
All
Okay.
right.
If you're giving lichenoid dermatitis 0.5, then atrophic lichen planus is also 0.5. Lichen planophylla is definitely not. Secondary syphilis, I don't know where they came up with that. Benign lichenoid keratosis. That is for a single lesion. It's not for multiple lesions like this, and the clinical is that of lichen planus.
We cannot give any credit for that.
Cannot give anything.
Yeah.
Actinic lichen nitidus, again, this is not lichen nitidus, unfortunately. Probably, I don't know why they call that. Pseudokaposis sarcoma, if you're seeing vascular coefficient that resembles Kaposi sarcoma, fair enough, but not just dilated capillary. So definitely not that. Pityriasis lichenoides chronica, I guess they saw the spongiosis and they saw the lichenoid infiltrate and thought pityriasis lichenoides chronica. But for that, the spongiosis is much more marked, the lymphocytic exocytosis is much more marked, and the parakeratosis should be confident. And there's hardly any parakeratosis here. So that's not the answer. Prurigo nodularis, again, not enough of vertically aligned collagen fibers, etc. to call it prurigo nodularis, though there is a bit of spongiosis. I don't think that should be given any marks, but any objections for me to not giving any marks?
No, we cannot give any marks for that.
Okay, so we'll submit case 1, and that will be the final marking for that. Okay. So going on to case 2, once this saves up. Yeah, okay. Let's go to case images. Case 2. Dr. Sisi, are you here? Anybody else here in the panel, or is it just Dr. Anmol still? Okay, Dr. Anmol, you're the only one still, so until Dr. Sisi Das joins. So next case is also yours. Dr. Sisi Das is here. Excellent. Welcome, Dr. Sisi. So Dr. Sisi Das is one of the quiz winners from last time as well. So welcome, Dr. Sisi, and he is one of my helpful co-editors of the Indian Journal of Dermatopathology and Diagnostic Dermatology. Welcome, Dr. Sisi.
Good evening, sir.
So you probably this is the first time you're on the panel, Dr. Sisi. So
I think he has participated before, isn't it?
Oh, you there before? Okay.
One time before.
Yes.
Okay. Excellent. So you know how this works. So this is case number 2, 25-year-old female with multiple papillary lesions on neck and upper chest. So I'll just guide you through this, Dr. Sisi, and you can see what you think of this. You've probably already seen this case. So this is the low part. Do you want to describe what you're seeing?
So there is a acanthosis of the, you can see regular acanthosis here, and there is a large cystic space lined by stratified squamous epithelium, and the cystic space contains some keratinous debris.
Yes.
And there is mild inflammatory infiltrate around the cystic space. Within this keratinous debris, I think I saw a few hair-like structures, cut hair-like structures.
You mean hair shafts, right?
Yes, hair shafts.
Yes, they are hair shafts. So this is one, and there probably are. This is one more. You did see hair shafts, and this is one more. So these are all hair shafts, and they're pigmented, and that's the clue, and they're sort of slightly rounded. Quite right. Okay. And there's one more somewhere here, if I'm not wrong, but yeah, that's one more here. That's there. Can you see that? Yeah. So these are all multiple hair shafts. You're quite right. Okay. So where are we getting at, Dr. Sisi?
Sebaceous structure adherent to the cystic epithelium.
Mm.
So going by the clinical history of the typical age, I think eruptive vellus hair cyst would be my first top differential.
Excellent. Excellent. And what about the epidermal changes?
Epidermal, I cannot really fit into the diagnosis. So there is acanthosis, some regular acanthosis, and some follicular induction is there, but I'm not very sure.
Okay. So there is definitely irregular epidermal acanthosis. There is focal hypergranulosis, compact hyperkeratosis. Okay, no parakeratosis, no spongiosis, or very minimal spongiosis if at all. And there is a non-specific pericystic and perifollicular as well here, lymphocytic infiltrate, which is all probably reactive. I think this is probably reactive change. The patient probably has been picking the lesion or been traumatizing it because the lesion was probably itchy or they didn't like it and they were scratching at it. And those are reactive changes in my opinion, but you're quite right. Here you have a small cyst in the upper dermis lined by, stratified squamous epithelium, and you're seeing the keratin debris in the middle and hair shafts. And given the multiple hair shafts, you're thinking about eruptive vellus hair cysts. If if you didn't see hair shafts, and given the clinical history, what would be your diagnosis, Dr. Sisi?
I would look for any sebaceous structure in deeper cuts and think of steatocystoma multiplex.
Excellent.
Or,
so what is the against steatocystoma multiplex in this scenario? Even though you're not seeing the sebaceous gland, what other feature is against steatocystoma multiplex?
I sent a message just now. See if you can join.
I think the hair shafts are what, and also the keratinization pattern is not like steatocystoma.
Yes, you don't see this multi-layering. Also, you see a crenulated epithelium, isn't it?
Yes,
in steatocystoma multiplex, we often see a crenulated lining,
yes.
wavy lining, and that's typical of steatocystoma multiplex that you're not seeing. Okay, steatocystoma multiplex apart, is there any other differential diagnosis if you're not seeing the hair shafts?
Maybe a giant milia or a comedone.
Yes, multiple milia. Excellent. So your patient can have milia, multiple milia can also be there. And a milium cyst exactly looks like that. A milium is an epidermoid cyst, and a milium exactly looks like that. Anything else to contribute from the panel, Dr. Anmol, Dr. Nandakumar sir, Manoj Singh sir, anybody else?
No, I don't think so. Only thing is, for an inexperienced pathologist without the clinical knowledge, we shouldn't get carried away by the changes seen in the epidermis and miss the diagnosis. That can happen. We shouldn't miss the diagnosis for the overlying changes in the epidermis. As you said, it could be due to the patient scratching or something like that. So the basic pathology is the cyst. So,
yes, I think it takes multiple, you need to see multiple cases. You need to correlate with the CPC, with the clinical to actually understand which pathology is secondary and which pathology is primary. And that's the most important thing to recognize as a reporting pathologist or a learner. And often, as you say, for inexperienced people, this can be quite confusing when you're seeing these epidermal changes and then the pathologist is just describing something underneath and ignoring the epidermal change. Often we don't even comment on the epidermal changes. If you're signing this out, we may not comment on it. We just say consistent with whatever the diagnosis or steatocystoma or eruptive vellus hair cyst and sign it out and leave it at that. And then if somebody is looking at the picture, they may be confused and thinking, why did they not comment on this? Okay. So if there are no further comments, I'll just close this and go on to the answers because it's a straightforward case. We can discuss the other case in a bit more detail. So going to case number 2. Manoj Singh sir, did you have anything else to comment?
Not particularly. I think this is a very interesting case for discussion because, as we have here in the diagnoses, the discussion goes about the clinical presentation because and especially if as very frequently when I get these biopsies with very minimal history, and then to call this if it's a solitary lesion and you have that history, then you think of epidermoid cyst, and then you have the differential diagnoses of that. Do you have multiple lesions, grouped lesions? That's a different issue. But I think this is primarily a cystic lesion, for whatever having raised the point that this is a cystic lesion, and what is above it is, I think, reactive hyper keratosis, acanthosis, inflammation, perifollicular inflammation, and so on. I think all those are reactive features.
Yes, sir. And we did discuss a similar case before, and we did discuss that often there are multiple hybrid cysts sometimes, and if you do a biopsy of one lesion, it may turn out to be steatocystoma multiplex. Another lesion may turn out to be negative vellus hair cyst, and it is known that hybrid lesions and the combination of this occur depending on the level of obstruction of this of the folliculosebaceous unit. So I think it's important to recognize that overlaps exist, and making a misdiagnosis is not the end of the world. You can call it media, you can call it, but another day, as long as you recognize these are benign lesions and the part of the folliculosebaceous cyst spectrum, I think you're okay. So it's not a life and death issue if you misdiagnose. But still, for the purpose of this quiz, you need to get the diagnosis right. Epidermoid cyst, certainly it is. So that's the majority of the answer. But I expect them to make a diagnosis of eruptive vellus hair cyst, which is the main answer. So that is 1 mark. Epidermoid cyst, certainly it is. It is part of that spectrum. Should we give them 0.5 or no marks? Or what is the opinion of the panel?
0.5.
Manoj Singh said 0.5. You okay with that?
For an epidermoid cyst? Yeah, I guess so, maybe. But I mean, if a history is clearly given that this is a single lesion.
So let's do one thing. Let's give 0.25 to this one, and then we've got eruptomilia, which we can give. I mean, we can give 0.75 to that because eruptomilia is a good answer. They missed the hair shafts. So I don't know.
I think that's a better way of looking at it. Yeah.
Because a single lesion, they've identified the epitomoid nature of the cyst, so 0.25. Eruptomilia 0.75, eruptovellus hair cyst 1 mark. I don't think you're giving any marks to the remaining ones because steatocystoma multiplex, you need to have specific things.
Clinically, please tell me, would milia show such kind of chronic features?
No.
Depends on the lesion, also. So if you've sort of scratched it and if you've sort of traumatized it, secondary changes can be there in any lesion.
The overlying, like hyperplasia of the skin.
So the overlying hyperplasia, I think, is reactive, and that it is not typical of any lesion. That is not typical of any cystic lesion. It is just a reactive change incidentally seen in this particular case. But that shouldn't, I mean, that is not a feature of any of these cases. It's just a reactive thing that can be seen in any lesion, in my opinion.
Yeah. Okay.
I don't think we should give any marks for steatocystoma multiplex because there are no signs of it. Comedone nevus, yes, I mean, but no nevus, it's not nevus, so I don't think we should be it's a comedone, fair enough. Comedone is a reasonable diagnosis like epidermoid cyst. Comedone is an epidermoid cyst, but then it's not really a comedone, it's quite deep. So I'm not sure. Are we giving any marks for that?
I don't think so.
If you're given eruptive milia 0.75, milia by itself 0.25 is reasonable because they didn't say eruptive. Or if you're feeling more generous, we can give 0.5. But if you gave epidermoid cyst 0.25, milia by itself, what do you think? 0.5 or 0.25? 0.25 I think is reasonable. If you're
0.25. 0.25.
0.25.
Epidermoid cysts with hyperplasia. So somebody has recognized the hyperplasia on the epidermis, but I don't know. I don't epidermoid cyst. I'm not.
Again,
0.25 again. That's it.
0.5 perhaps. This person has commented about the
Epidermal
significant
hyperplasia.
hypoplastic component also.
Okay. So 0.5 for that being a bit more generous. I think that's it. Vellus cyst. I think that vellus cyst. It's I think the same as eruptive vellus hair cyst. So should we give that full marks? What does vellus cyst mean? I mean, it's a plural thing.
Well, I think then that should be listed with together with the first one. The earlier.
Eruptive vellus hair cyst. Shall we give them? Nandakumar sir, are you feeling generous or 0.75 or what?
I am 0.75 because here
0.75. I think 0.75
that
I think is reasonable. I'm also 0.75. Okay, let's submit this and go to case 3 quickly. So case 3, going back to the images. So Dr. Anmol, case 3 is yours. Lesion on the perianal area of a 31-year-old male, nothing else given. So this is the 31-year-old male perianal area.
Yeah.
What do you think?
So at scanner view, I can see this is the endophytic lesion. I can see strands of epidermis which are interconnecting and branching and going downwards. But it seems to be not very infiltrating and circumscribed from that. In the right middle section, I can see the end of this infiltration. And there is also area of erosion with pinkish material. I think that is will be exudate on this top of epidermis.
Yes. Okay, I'm going higher power, so maybe you can comment on the nature of the cells, etc. So yes, you're seeing a bit of spongiosis and parakeratosis and serum crust. So that is probably reactive and you can ignore that. But what about this main proliferation here? That is the main diagnosis, right?
Yes,
What do you mean to make of this?
So I was not able to appreciate any ATPia.
Okay. What are the nature of the cells?
The epidermis, they looks like epidermal cells and they look
okay.
normal.
Right. What does the low power pattern remind you of?
What? The endophytic nature of what?
A what? Okay. Okay. Anything else you may want to think of apart from a what?
So poroma, but that has thicker strands than that basiloid follicular hematoma.
Yes, poroma can sometimes, can present like this. Manoj Singh sir, I think this is your forte. Do you want to comment on this?
Yeah. Have we reached the diagnosis level?
No, sir. I just want you to guide Anmol and see what else.
Can we see the other sections also?
We need to, I think, concentrate on these the multiple island-like picture in the mid and lower dermis, and also the fibrotic and vascular proliferative changes there. And then, of course, we look at the nature of these epidermal strands and what they are looking like individually. After this thing is over, I have a brief comment to make about this particular lesion also. So that's all.
Nandakumar sir?
I think Dr. Anmol mentioned about he thought about the possibility of poroma, isn't it? Eccrine poroma.
Yes.
So do you think the lesion to be of an eccrine origin?
No, so I was not able to appreciate ductal differentiation as well as the small polygonal poroid cells. I was not very able to differentiate. So
I'm not saying
some
that.
some some stages I thought there were some transition cells, but these strands were very thin. So I had some doubt.
Do they look like normal epidermal cells or are they smaller? No?
So
They
slightly
are
smaller.
smaller, isn't it? We are seeing this strand-like downgrowth intervened by this fibrotic stroma. Dr. Sisaradas, do you have any comment? Are we dealing with an inflammatory condition or a neoplastic condition?
Sir, I think this is reactive condition actually. So these are basaloid cells making interconnected anastomos in pop.
Right now we focused on duct-like space, isn't it?
Yes,
Duct-like structures.
there is ductal differentiation.
Yeah.
Fibrovascular stroma within each of the.
Correct.
Yes.
It doesn't show any coilocytic change or it doesn't show any viral cytopathic change. So viral what is out of question. So it's mostly it's a neoplastic condition, isn't it? What we are looking at.
I think it is reactive in most cases. My diagnosis is ESFA, eccrine syringofibroadenoma.
Eccrine syringofibroadenoma. Can you just summarize the findings that you expect in an eccrine syringofibroadenoma?
So it would be an endophytic pattern of basaloid cells going in thin strands with interconnecting anastomosing cords, and the fibrovascular stroma is prominent, and there may be ductal differentiation at places.
Dr. Anmol, you are able to appreciate the ductal differentiation, isn't it?
Yes, sir. Yes.
Foci of ductal differentiation.
Yes.
Unless you have seen this lesion before, you will not diagnose it. So it is not surprising that you have not picked it up.
But I have to say, Dr. Sisaradas, big round of applause to you for actually getting this. For as a dermatologist to get this is actually brilliant, actually.
Absolutely. Yeah.
Oh, yeah.
This is indeed a eccrine syringofibroadenoma, and the features you've described are classical. And the differential here is a pincus tumor. And I thought, I just wondered if somebody would give the diagnosis. Maybe somebody in the audience has. I have to check.
That is my clue. If it looks like pincus but not exactly pincus, then it is ESFA for me.
Yes. And pincus is different because the branches all join together in pincus. Here there is the base, and it's more basaloid. This is not basaloid. This is more poroid, as Dr. Anmol has rightly picked out. This is more poroid. The cells are quite poroid. There is a bit of spongiosis, but that is probably just reactive to the chronic scratching or whatever the patient is doing, because there is sebum crust, etc. The spongiosis is there, and the cells look eccrine, they look poroid. They don't look basaloid, and that is the difference between a pincus tumor, which has these anastomosing cords, and the anastomos all joined together at the base. And that is how a pincus tumor, which is a variant of BCC, differs from an eccrine syringofibroadenoma. And you don't see the stromal changes in pincus as much as you see in this entity. Okay. Any other comments?
I think Dr. Manoj Singh wanted to make a comment.
Manoj Singh sir has left. He's there.
No.
Manoj Singh sir, do you have anything?
If you remember, I meant to submit a case of pincus for scanning and all that. And recently, I mean, that's just been a thought in my mind. And recently, in fact, then I saw actually a basal cell carcinoma, which pretty large carcinoma, in which in one area there was this kind of a change also. So I am going to look at my review all my morphology of all my cases of a couple which have been signed out as pincus and definitely basal. What I request you people to do is to pull out your basal cell carcinomas and other lesions perhaps, and see if this kind of a morphology, this Pincus-like morphology on growths on low power, whether you see it under other lesions or other areas also. I think we might benefit from a close study of this particular morphology. So let's I mean I plan to look up and maybe review all the cases. You might like to also pull out your cases and see if this.
Yes, sir. So looking at the answers, 14 people have called it condyloma acuminatum. I guess they saw the
History.
epithelial proliferation, but it's an endophytic lesion. The condyloma is an exophytic or maybe exoendophytic, but it's predominantly exophytic. This is endophytic and this is not condyloma accumulatum. This is not molluscum contagion. I don't know why molluscum has come into the picture. Any idea why people would have thought molluscum? Dr. Anmol and Dr. Sisidas, did you think about molluscum? I don't know. I mean, I find it difficult to understand. Honestly, don't know.
I think. Yeah, please.
I think the perianal site completes some.
Okay, just based on site. Okay. Fibroepithelium pincus, 4 people have called it that. So, but unfortunately, it's not. Eccrine syringofibroadenoma, only 2 people have called it, and that's the right answer. No answers to any of the others. Reactive eccrine syringofibroadenoma. Yeah, that's the same thing. So yes, that's getting 1 mark as well. Syringofibroadenoma, is there something called standalone syringofibroadenoma? It's the same spectrum, right? There's nothing else called a syringofibroadenoma. Dr. Nandakumar, sir, do you think there's anything else?
No, I think it's the same condition.
Same condition, right? So we can give it 1 mark. That's okay. Hybrid anogenital verrucous carcinoma. I don't know why that came into the picture. Warty diskeratoma, skin tag. So I don't think anything else is getting any marks, right?
Right.
Happy with that. I'm going to submit that and go on to the next case. We've got 3 more cases discussed, 10 minutes each. So case number 4 will be the next one. So since Dr. Sisidas got the last one, we'll give this again to Dr. Anmol again. So Dr. Anmol, this is Nandakumar sir, you may want to go through this with him, but I'll go through the history first. So 58-year-old woman with recurrent crops of superficial pustules over the trunk, axillary groins and inframammary folds for 8 months. Lesions begin as small flaccid vesicular pustules and enlarge centrifugally to form annular and serpiginous plaques with collarets of scale. She reports mild burning with little itch. Several pustules rupture within 1 to 2 days and leave superficial erosions. But new lesions continue to appear at the margin. Sometimes the history is very good, isn't it? She was treated elsewhere as pustular psoriasis with topical steroids and short course of oral antibiotics with only partial improvement. She's afebrile and systemically well. Mucosa is spared. Clinical differentials given now are it's interesting. Now we have to differentiate between all these similar entities. One is pustular psoriasis. Second is subcorneal pustular dermatosis. Third is IgA pemphigus, obviously the subcorneal pustular neutrophilic variant, the intra-abdominal neutrophilic variant, and then impetigo or tinea incognito is the other differential given. Now these are the lesions. You can see the clinical photograph here. You can see multiple pustules on erythematous background, and you can see here the pustules here as well on erythematous background. Okay. So the clinical, I think, photograph would be the very important clue and also the history. So let's basically go to the histology. Okay. Okay. Dr. Anmol, you and Dr. Nandakumar sir can tease us out.
Sir, at the scanner view, I can see there is a localized collection in the upper epidermis, and I think that is the main pathology. In dermis, I can see some reactive inflammation. I would like to see in the epidermis what is it.
I would like you to call this as an intraepidermal pustule.
Intraepidermal pustule.
And within the epidermis, where is it located?
Sir, it is located subcorneally.
Yeah. So we are seeing a pustule, very localized pustule just beneath the stratum corneum.
Yes.
Can go closer
So,
and identify the nature of the cells.
so there are it is neutrophils only,
Yeah, predominantly you can see the
predominantly.
polylobated polymorphonuclear leukocytes, isn't it?
Yes.
What else you will look in the inside the pustule? What else you should look for?
Sir, for acantholytic cells, but I cannot appreciate here.
We are not seeing any acantholytic cells. Any other finding that you would look for? You would also like to see whether there are any diskeratotic cells, isn't it? There are
Yes.
no
There
diskeratotic
there were
cells.
no dyspractic
Yeah.
cells.
Just the epidermis just adjacent to pustule shows little bit of spongiosis and exocytosis, but is the spongiosis very marked?
No, sir.
No. And what are the changes in the adjacent epidermis, if there are any, that you should
So
look for?
there is hypogranulosis. Other than that, there is just mild there is orthokeratosis, and other than that,
So, on the whole, the rest of the epidermis looks normal, isn't it? Is
yes, sir.
uninvolved. We are seeing a very localized subcorneal pustule composed
One
predominantly
is here as well.
another one is there here. Predominantly of
Yes.
polymorphonuclear leukocytes, no obvious acantholytic cells, very minimal spongiosis and exocytosis just beneath that. And in the upper dermis, we are seeing some. What do you see in the upper dermis?
So
Can see some dilated capillaries,
dilated capillaries and lymphocytic infiltrate.
few extravasated RBCs, and it's predominantly lymphocytic infiltrate. So, I mean, with the clinical picture, what is the most likely diagnosis?
So subcorneal pustular dermatosis.
Yeah, why I mentioned those negative points, the important negative points, because one, the presence of acantholytic cells and diskeratotic cells can point us towards another diagnosis. Which condition will show a subcorneal blister with acantholytic cells and diskeratotic cells?
So acantholytic cells can be seen in a subcorneal variant of IgA pemphigus.
Correct. And it can show some diskeratotic cells also. But the architecture of the pustule is very characteristic in this slide, in this case. And another differential offered was whether it is a pustular psoriasis. Can this be pustular psoriasis?
Sir, I will not have pustular psoriasis because this pustule seems to be just sitting at one or two places and rest of epidermis is unaffected.
There is no parakeratosis, and the adjacent epidermis doesn't show any psoriasiform hyperplasia. So, histopathology wise, it fits in very well with subcorneal pustular dermatosis. And we would, what special stain we would ask for if you want to? You can do a gram stain. You can do a gram stain, you can do a fungal stain, just for the sake of completion, because such a long history, fungal stain, even if it is positive for fungus, we cannot straight away call it as tinea incognito or anything like that. It can be a secondary infection. Similarly, presence of bacteria per se shouldn't take us away from the clinical picture. It is not that of impetigo. But these two stains, if it is an acute presentation, these two stains can also be done. But otherwise, histopathology-wise, this is a straightforward case of subcorneal pustular dermatosis. The key statement regarding the pathology of SCPD is that the spongiosis is minimal or absent in SCPD. If you find prominent spongiosis and exocytosis, we should consider alternate diagnosis also.
Okay.
Excellent explanation, sir. I think it's a very difficult case for juniors because all subcorneal pustules look the same. And to tease this out and to make a diagnosis of subcorneal pustular dermatosis needs finesse and expertise. And that is where that is what divides expert from the others. One particular point I wanted to ask: do you think this is vacuolar interface change?
There is.
So this is what I want to point out in the earlier lichen planus. When you're seeing focal vacuolar interface change, this does not make it lichen planus unless there's a clinical context. And often
Correct.
we see this focal vacuolar interface change even otherwise in normal incidentally. And
Yes.
we should not be confused by that. And we should be guided by the predominant picture rather than by the incidental findings. But all this extravasation of RBC, I think, again, is a very important clue. So this much of extravasation of RBC is not normally seen in non-acute lesions because this is a relatively acute lesion. Extravasation of RBC is seen, and that is not normally seen in psoriasis or other entities. SCPD is it's an acute pustule, and you may expect this sort of changes. Manoj Singh, sir, any other comments before we move ahead? Manoj Singh, sir, any comments? You're on mute.
No.
Okay, fine.
I have one question.
Yes, sir, go on.
Sir, would you also get an acantholysis in impetigo as well?
See, focal acantholysis can be seen in any entity, but extremely rare. We should be guided by the predominant pattern and the history. Nandakumar, sir, sorry, you want to say?
Even in SCPD, we may see 1 or 2 acantholytic cells, but with the predominant or the overall picture is that of SCPD. I agree that the secondary acantholytic changes can occur.
Okay, so let's move on to the answers. So question number 4. Okay. So subcorneal variant of IgA pemphigus, a lot of people have called it.
Yeah.
That has seemed to be the predominant answer. I mean, we can give them some marks.
Sir, I can give an explanation for that, sir. There was no option of plain subcorneal pustular dermatosis. There was only 2 options. The first 2 ones.
Oh, is it? Sneddon-Wilkinson
Yes,
disease?
sir.
It was there. Sneddon-Wilkinson
Oh,
disease.
I missed that, sir. Because I typed subcorneal pustules and there were only 2 options. So I thought maybe one of.
Fine, fair enough. I guess in that case, if majority of people were misguided by that, then you should have called it at least drug-induced subcorneal pustular dermatosis, which is obviously, I mean, that is also an answer. So if people found it difficult to find subcorneal pustular dermatosis, maybe we can give. I mean, this is obviously one.
But I think extra credit should be given to the person who identified it as Sneddon-Wilkinson's disease. At least he knew that name, no?
Yes, true. Then we should give them 0.75 for the remaining ones.
Yeah, exactly.
0.75 for the remaining ones. Pustular psoriasis, I mean, It's a differential, so you can call it that. I don't know if you should give any marks in this, and maybe 0.25 for the remaining ones. I don't know. Or no marks. What do you think, sir? Are we giving any marks for pustular psoriasis?
No, we shouldn't.
Okay, because that's there in the clinical history. It's easy to put the diagnosis anyway. Tinea, no. Intraepidermal neutrophilic IgA pemphigus. I mean, this is.
I mean, there is no acantholytic cells, no?
Yes. Spongiodic dermatitis and impetigo, no. Okay, so I'm submitting this as it is. That's the marks, final marks. Okay, excellent. So next, going on to case number 5, there were 52 participants, by the way, so that's quite a good number this time who've taken the quiz. Case number 5, let's see what is this. So Sisir, you can go with this. This is a similar case, so very interesting to see if you get the same diagnosis or different diagnosis. This is a long history again. 40-year-old male presents with recurrent coughs of sterile pustules of the trunk, proximal limbs, inframammary folds, and groins for 6 weeks. Lesions began as superficial pustules or erythematous plaques and gradually enlarged to form annular and polycyclic plaques with peripheral pustulation. Superficial scaling, he reports burning more than itching. He had an episode of sore throat 3 weeks before the eruption worsened and was treated with oral antibiotics. The rash was initially diagnosed elsewhere as infective pustulosis impetigo, later as subcorneal pustular dermatosis, but repeated antibiotic courses gave no sustained effect. On examination, there were multiple erythematous scaly plaques with peripheral pustules over the trunk and flexures. Some pustules were superficial and flaccid, but there was background psoriasiform plaques on elbows and scalp, which the patient says have been persistent intermittently for several years, never formally diagnosed. Nails show subtle pitting, distal ankylosing. He's afebrile, mucosa spent. Now remember, subcorneal pustular dermatosis can also occur in a patient with psoriasis. So we have to now see what this is. Is it subcorneal pustular dermatosis, pustular psoriasis, AJEP, acute generalized exanthematous pustulosis, impetigo, IgA pemphigus. And this is the photographs that I've got here. So that is one photograph. And this is the second photograph here. Not high quality, but you can see erythematous scales and plaques over which there are pustules. Okay, let's see if this histology has got more clues. This is maybe a better image. This is a very superficial biopsy, as you can see here. So, Dr. Cecil Das, Nandakumar sir, you can again guide through this because you.
Yeah, Dr. Cecil Das.
This is a straight biopsy, and we can see a lot of serous exudates with inflammatory infiltrate in the corneal layer, and also some parakeratosis, focal areas of hypogranulosis with spongiform pustules, and these are predominantly composed of polymorphonuclear cells. There is a focal area of psoriasiform hyperplasia at the side also.
The other region here. Okay. Okay, go ahead.
So we get parakeratosis, we get subcorneal pustules, that is a spongiform pustule of Burgos, and some psoriasiform hyperplasia with hypogranulosis, and based with the impressive history, which probably points us to a case of unstable psoriasis, which is converting to a pustular one. I think my first diagnosis would be pustular psoriasis.
Yes, actually, we can compare the previous case with this case, isn't it? The first, starting with the architecture of the pustule, location of the pustule. This is more intracorneal and subcorneal. We are seeing a very prominent parakeratosis is there, and to add to that, just beneath the epidermis, just beneath is showing bulbous acanthosis, psoriasiform hyperplasia, and the other one is that the Kogoj abscess, isn't it? But we are seeing, I think it is in the other section. Yeah. So the parakeratosis, I hope, Dr. Anmol, you are able to appreciate the difference between this case and the previous case, and why we are calling this as pustular psoriasis and the other one as SCPD. That is the learning, that is the purpose of keeping these two slides.
Having said that, sir, these are very difficult cases, and I put this for discussion because I can imagine if we give it to 10 dermatopathologists, they may come up with 10 different answers.
Correct. I have gone wrong many times regarding diagnosis of pustular psoriasis.
This is not very easy, very difficult, I think. And sometimes, the key question is what difference does it make to the patient, what we call it. I guess drugs have to be ruled out if we are calling it SCPD or AJEP. AJEP is other differential. Sir, what do you think about AJEP being in this case? How do you differentiate AJEP from subcorneal pustular dermatosis? How easy is it?
I think the key feature is the upper dermis. In AGEP, one expects a very busy upper dermis along with dermal edema. Here, the dermis shows a very moderate number of inflammatory cell infiltrate. Whereas in acute generalized exanthematous pustulosis, the upper dermis will be very prominently involved with edema and inflammatory cell infiltrate. And presence of neutrophils also.
I think the key learning point for people who are viewing this, the audience, is that these are very difficult cases. And differentiating them can be very difficult sometimes. This is not easy. And as easy as we made it out to be, we are sitting from a retrospective point of view. We know the diagnosis.
Correct. We
But
need
sometimes,
we need CPC, and we need lot of CPC. Dr. Sisirdas, any comment regarding the possibility of AGEP in this case? Again, a very, very difficult condition to diagnose, isn't it? AGEP, histopathology wise.
As a clinician, I think any drug eruption should follow the particular history. So without history, we should not jump to any drug eruption as such. But we can ask the clinician, especially if there was neutrophils lying around the dermoepidermal junction here.
Correct.
Sort of it.
Yeah. So the upper dermis holds the key to diagnosis of AGEP.
So in this patient, they had antibiotics 3 weeks prior. So I mean, the history could be that, but the clinical presentation is atypical because this is not a presentation of AGEP. The pustules are often not distributed amongst the existing plaques or erythematous base. You don't have that.
Patient will have systemic features also, very toxic and.
Yes. Dr. Anmol, do you have any questions? This is a difficult case, so please feel free to ask because the audience may have similar questions. I want all of you to ask as many questions as possible. Any questions, Dr. Anmol?
No, sir. Initially, I just had doubt whether this pustule was subcorneal or intraepidermal, but at the lower end, it was going intraepidermal. So I thought it was spongiform pustular purpose.
Yes. Manoj Singh, sir, do you have anything else to add?
No.
Okay. So we'll go on to the marking of case number 5. I think we can be a bit more generous with the marking here, but we'll see what everybody has answered. Pustular psoriasis, I think most of them answered, so I think this is excellent.
We are underestimating our.
They're better than us, maybe. Okay. Subcorneal pustular variant of IgA pemphigus. Unfortunately, in this case, I'm not going to give any marks. Difficult to actually call it IgA pemphigus without any other clues. AGEP, 7 people have called it. I mean, I don't know.
No, we cannot. We cannot give it any marks.
Yeah, drug-induced subcorneal pustular dermatosis, because there's a history of drugs. I think that is a reasonable differential.
But I mean, what about the additional histopathology features that we see in this slide?
Okay. But patient has a background of psoriasis. On psoriasis, can he not get subcorneal pustular dermatosis as a
correct? Maybe 0.5 or 0.25 maximum.
Yeah, okay.
Especially if there is a history of treatment with an antibiotic for some kind of febrile episode that was in the. I think that would have led to this.
Yes, because we cannot entirely rule it out, right? Drug-induced condition, because the antibiotic history cannot entirely be ruled out. Okay. Manoj Singh, sir, do you have any major things about how many points to give to this? Any?
For drug-induced.
Drug-induced.
I think I'd say either 0.5 or something. Not even
0.5. Okay, 0.5 it is then. Okay. Impetigo, no marks. So submitting this, and then we are up to the last case. Excellent. So last case, I think Dr. Anmol has had a significant share of cases. Shall we give this to Dr. Sisirdas, or both of you can comment? Asymptomatic indurated plaques on the trunk since 1 year. Very vague history, no age, nothing here, which is what can happen sometimes. So let's see what this shows. Asymptomatic indurated plaques since 1 year. On the trunk, obviously. So, Dr. Anmol, do you want to comment? And then maybe we can just Dr. Sisirdas also comment.
Sir, that low power, I can see there is epidermis is thin and rested. There is a small zone of sparing, I think granule-like thing beneath the epidermis. Then there is a zone of cells which I can see in the epidermis, and there are also some curvilinear collections of cells in the epidermis. So I was on pattern basis, I was thinking if this could be leprosy or anything else.
Okay, Dr. Sisirdas, have you anything else to add or comment?
Yes, sir. I also thought the same way, but and there is some epithelioids, histiocytes are present.
Oh, that's later. This is just low power.
Okay, sir. In low power, I think I also thought the same.
Is there any other differential? So both of you thought leprosy pattern.
Leprosy pattern, and I also think of dysbiosis in this setting because
Leishmaniasis, okay.
the curvilinear pattern is not very tight or
Okay. Especially probably because specimen is slightly distorted and it's a superficial biopsy, you may think that.
slightly.
But Dr. Ramam sir, I think we have to, he's named this particular pattern as leprosy pattern, the curvilinear pattern. We know this is curvilinear pattern, but it's nice to call it the leprosy pattern because you don't see this in any other entity. And yes, you're right to think about other differentials, but once you see this, this curvilinear infiltrates, I think you got your diagnosis even before you go into higher power. Okay. So let's go higher power. Dr. Anmol, you mentioned a Gren zone. And how
Yes.
important is the Gren zone in the diagnosis of this entity, you think?
Sir, I was thinking it is belonging to the leprometa spectrum. That's why it is having Gren zone. That's why there was no giant cells.
Okay, so you're thinking leprometa spectrum, therefore Gren. Is the Gren zone very diagnostic? How specific or how sensitive is the identification of Gren zone in the diagnosis of leprosy? And if in leprosy a Gren zone is found, which spectrum would you put it towards?
So I think it suggests toward multibacillary spectrum, and I'm not sure of sensitivity or specificity as such.
Okay. So multibacillary spectrum, leprometa spectrum, you often. Dr. Sisildas, do you have any comments to make on that?
Sir, I don't give Gren zone much importance, especially in leprosy, but more often we find it from BT onwards towards the LL code, never in.
Yeah. I mean, in tuberculosis spectrum, you have in fact see a lichenoid and granulomatosis spectrum, in fact. So there is often a basal interface change in the tuberculosis spectrum. And that's why often you see hypopigmented patches as well. There's interface change. But you're right. Gren zone has least specificity. Sensitivity maybe is slightly higher, but then, specificity is very low. And even in the lepromatosis spectrum, if there have been studies that they've done PCR and they found bacilli within the epidermal basal membrane layer as well. And I have lepromatosis cases with complete epidermal atrophy and no Gren zone at all. The infiltrate completely fills up the papillary dermis. So Gren zone is non-specific and sensitivity is more towards the lepromatosis spectrum. You're right, but don't use it as a diagnosis or I don't even often mention it because it doesn't veer me towards anything at all. It doesn't actually help me in any way apart from maybe helping me decide the spectrum a little bit. But the spectrum to me is decided by the nature of the infiltrate, correct? The infiltrate, Dr. Anmol, you rightly point out there are no giant cells. What are the nature of the infiltrate, Dr. Anmol? What do you think?
So there are histiocytes, a few epithelioid cells, and there are foamy cells.
Yes, it's predominantly foamy histiocytes, epithelioid cells, and lymphocytes. So given that, I mean, this part of the biopsy is not so clear. Yes, here it's scanned well. So you see, given the nature of the infiltrate, one would think about the lepromatosis spectrum rather than tuberculoid spectrum, where you would expect to see more granulomatous changes. Here, there are no well-formed granulomas, though the infiltrate is discrete, following the neurovascular and bundles here. You can see that lymphocytes, histiocyte, following the neurovascular bundles. Have you identified any nerves? I'm not sure if there were any nerves.
I was not able to identify nerves.
Yeah.
What? The left, towards the left. Towards
Here maybe. Are there any nerves? There may be. I mean,
there's one. This large infiltrate.
This here, I'm not sure if it's a nerve actually. This is a blood vessel here. You can see the RBC within it.
No, sir.
This may be right. Maybe these are slightly wavy cells. So this may be a nerve, but it's quite thick actually. It has to be a huge nerve for there to be a nerve. Maybe difficult. One of the main features, other features to diagnose leprosy is periacrine infiltrate. Often when you don't see periacrine infiltrates in a number of entities, when you're seeing periacrine lymphohistiocytic infiltrates, think about leprosy. That's often not a feature that is well described. Also, one of the other features is this. Often you see peripilar infiltrates. I don't think you're seeing them here, but often if you're seeing peripilar infiltrates, the pilar muscle being destroyed, that again is a feature. This is a sebaceous gland around which there is a lymphohistiocytic infiltrate.
Can this be a nerve? No.
This one, sir? I don't
Yeah.
think so.
I don't think so.
No.
I think that's just collagen bundles sometimes.
Yeah, it is.
Often
Yeah,
find
it is.
them thickened.
Correct.
And,
Not this, but what we were seeing earlier, I think, was a nerve.
Yes,
Yeah.
the earlier one probably is a nerve.
Part of
That's
the
what
inflammation.
identified probably is a nerve.
What you
without staining. This one.
Yeah, what you mentioned about rectal pili infiltrate, that I have found to be a very useful clue in diagnosing difficult cases of leprosy.
Dermatopathological infiltrates, periacal infiltrates, and I think those are the good clues. So this is in the lepromatous spectrum, and given the nature of the lesion, it's a single plaque. I think, and the fact that the infiltrate is relatively sparse, you put it in the borderline lepromatous spectrum, right? Do you agree?
Yes.
Would you put it in a lepromatous LL spectrum? I mean, clinically, LL presents with much more numerous lesions. Given the single lesion and the fact that it's following a curve, normally in the LL spectrum, the infiltrate is much more dense, diffuse, and it occupies the entire dermis.
Yeah, this localization will be lost in frank lepromatous spectrum.
In frank lepromatous. Anything else to comment, Dr. Cecil Das or Dr. Anmol?
I thought actually this would be a BT lesion. Multiple lesions of BT can be a diagnosis because there are some epithelioid-like cells, but which are tending to form giant cells at some places. And
did you see any giant cells? I probably missed that. Where were the giant cells, Dr. Cecil?
Sir, I exactly don't remember, but there are some epithelioid cells. Can you go to the right? Can you go to the right?
So epithelioid cells can be present. See, epithelioid cells per se does not make it tuberculoid spectrum. Epithelioid cells can be present even in lepromatous spectrum. Not all cells are foamy, only some cells are foamy. Some of them are just epithelioid. So yes, some of these cells are epithelioid, fair enough, but doesn't make it tuberculoid unless you're seeing well-formed granulomas with giant cells, and I wouldn't particularly call it tuberculoid. Having said that, the spectrum can vary from lesion to lesion even within the same patient. So I've seen patients who clinically look like tuberculoid spectrum, and the biopsy shows lepromatous changes with foamy histiocytes and numerous AFB as well on fight for staining, and the other way around as well. So I don't think you can.
I was looking for diagnosis which says BT progressing towards BL, but it was not there. That would have been my call.
Okay, you think it's it's actually converting. You think it's a reaction. If it's BT progressing towards BL, you're calling it a reaction almost.
Not exactly in reaction.
Downgrading reaction.
Okay, you can. I can get a reaction if I see other clinical features also.
Yes.
Do you feel that the disease started as BT and it is now it is downgrading into BL? That is what you are saying, isn't it?
Yes, sir. Rather than pure LL form.
Why not? It's a single plaque, so why not BL now developing immunity over the last 1 year and upgrading into BT now? Why not the other way around? Because it's a transition. It can be both ways, right?
It can be.
Sir, I think in history you have written plaques, so I thought it was lepromatous leprosy.
It is not frank lepromatous leprosy. Dr. Cecil Das, we don't expect form cells in borderline tuberculoid leprosy. We do not expect. So if we find form cells, it is unlikely to be borderline tuberculoid. I mean, Dr. Sasi, Dr. Manoj Singh, your opinion, please.
Yes, sir, I agree. Manoj Singh, sir?
No, nothing to add. No.
Yes. Okay. So I think we've discussed this enough. Let's see what everybody else has answered on this one. Case number 6. Morphia, I don't know where that came from. Interesting. 20 people have called this morphia because it's called it integrated plaque on the trunk. People have called it morphia without even looking at the histology, I guess. Okay. So BL Hansen's gets 1 mark. I'm giving that here. Lepromatous leprosy, is second popular answer. Single lesion. I think it's in the lepromatous spectrum, but maybe
Give 0.5 marks because the CPC is not.
yes. 0.5 I think is reasonable if you're not giving anything else, any other marks. I mean, the fact that they've called it Hansen's, BB is the other thing. 0.25 on that one. I don't know.
0.25.
Yes. BT, I don't think we should be giving, I mean, maybe 0.25, I don't know. They call it leprosy. They call it leprosy.
They have called it leprosy, but the concept of the spectrum is wrong, no?
No,
Okay.
But still, they call it leprosy, sir. I mean, they've not called it sarcoidosis, they've not called it cryptococcus like the others have.
I will leave it to Dr. Manoj Singh to arbitrate.
I think that lepromatous leprosy should get 0.75.
Okay, lepromatous 0.75. I think that's okay. Actually, if
Yeah.
then that make it easier for us to do it. Okay.
What about BT leprosy, Dr. Manoj Singh?
I am intrigued by why so many people are calling it a fibrous-like lesion, lichen sclerosis, morphea. I didn't see very much, fibrosis or sclerosis in the dermis. So I'm wondering what they're actually,
I think they were influenced by the clinical history rather than anything else.
Indurated plaque, some people have called morphea, some people have called lichen sclerosis. So I guess they were influenced by history. Not everybody is well versed with histopathology. They're taking the quiz. So I would say don't be disheartened if you've given those diagnoses.
I really appreciate Dr. Anmol and of course, Zirdas, he knows histopathology. For picking up the leprosy pattern, I congratulate you. You did it very well.
Yes.
So if you're giving 0.75 to lepromatous leprosy, then BB gets 0.5 and then BT gets 0.25 because we're giving some marks to leprosy.
All right.
And then rest don't get any marks. Somebody has called it tumidally, histoplasmosis. I don't know where they saw it. Okay, I think we should discuss the histoplasmosis cryptococcus. I'll discuss that because I did wonder if some people call. There's a bit of dust in the slide.
There is.
Dust is resembling cryptococcus histoplasmosis.
But the point is that the foam cells are much more sort of prominent feature here.
Yes. No,
So
but a lot of people have identified organisms. I think that's because of dust.
But for calling it distinctly, either leishmaniasis or histoplasmosis, one has to see something. I don't.
Let me just submit this because I think we're done with this. I'll just go to the case again and we'll just see the dust. I think I wondered about this because I looked at the dust and thought some people might actually get confused. Let us go to that and then just quickly.
Yes, sir. I also, those dust could be some type of organism.
Yes.
I put leishmaniasis at 20% of probability.
So you see here, all this is dust actually. You can see this, all these.
At the photograph, you cannot see, you cannot differentiate between dust and any other foreign body. You have to drop the focus to get.
There is look at this thing. Yeah. This.
But you can see the dust present even outside the granulomas. And also the dust is not all of uniform. I guess you can call this a very capsular halo as well if you're thinking hard.
But they are not very prominent within the collagen.
Yes. They are there. Some of them are there. They are there. If you look at here, here it is, here the dust.
Yes.
And here's the dust. That's not within the infiltrate. So yes, I can understand why people have identified dust there. And I guess that's why you thought leishmaniasis, is it, Dr. Sasi?
Yes, sir. Because,
and look at this, dust is present even in the papillary dermis, and that is nowhere near the infiltrate.
Yeah.
I don't know. That's not the pattern of leishmaniasis. That's not how you would find the organisms usually. That's much more interstitial. Can you make it out here? Here, it's not within the histiocytes. It's all within the interstitium. But Nandakumar sir, what did you think that people would be confused? I mean, can you make out the dust?
I really didn't think about leishmaniasis. Now only seeing this. I didn't think about leishmaniasis.
No, I don't think we would think about it, but I can understand
Yeah,
knowledge.
I fully agree. For people who are, I mean, new to histopathology can get confused. And you rightly pointed out the naked dust in the papillary dermis, nowhere near the infiltrate. That is the way to differentiate artifactual material from true organism. That is one way.
Yes.
So the real confusion will start if both of them are present, both dust and organism.
Yeah, but then you have the leprosy pattern here. I think once you identify the leprosy pattern, I've not seen leishman. I have to admit, I've not seen leishmaniasis or anything else in the leprosy pattern. I mean, the pattern looks quite different. Dr. Nandakumar sir or Dr. Manoj Singh sir, have you seen leishmaniasis in the leprosy pattern?
No, I would not like to comment on that.
Nandakumar sir, have you?
The late lesions of leishmaniasis can show tuberculoid granuloma, sometimes mistaken as leprosy. In fact, in Kerala, I mean, years back, there was a large study in a tribal settlement where people were, I mean, at that time, only the health workers used to diagnose leprosy and treat. And biopsy was done and they were treated as leprosy, but subsequently, I think the diagnosis was changed to leishmaniasis, late lesions of leishmaniasis, were being diagnosed as tuberculoid spectrum leprosy. So that can occur, but not those lesions where it is teeming with organism. That doesn't show leprosy pattern. It doesn't. And in late lesions of leishmaniasis, we do not see any organism. We base the diagnosis on PCR nowadays.
Yes, yes. Excellent. So, Dr. Sisidas, you've scored the top mark again. Well done. Dr. Ambor has scored the third mark. So it's been excellent. I think all of you have done really well. Dr. Sisidas, I think you've done exceptionally well. So that's been excellent discussion. I think a good spread of cases. And any other comments or questions from the panel, from the faculty?
Just one comment. In fact, from the same tribal settlement, while I was in charge of the cytology lab, we collected around 15 cases. We did fine needle aspiration from the skin lesion, and many of them showed granuloma. We have published this as a paper in ICMR. This was an ICMR sponsored study. And the diagnosis of leishmaniasis was confirmed by PCR. So it can show granuloma. We could demonstrate granuloma in fine needle aspiration of the skin lesions in these people.
Excellent. That's good to know, sir. Okay. If no other comments, shall we wind up?
Yes, we are on time today.
Okay, excellent. Thank you very much, everyone, for joining in. And that's been an excellent discussion. And until next time, see you next month. Okay.
Good night.
Thank you. Good night.
Good night.
Good night.